Hello, everyone. Welcome to this digital health session. I'm going to talk about a project we carried out in Uganda called DiMHA, as you might have seen in the program. In other words, Digitalizing Mental Health Care Access in Uganda. And I would like to start with outlining the aim of the project. It was to improve access to mental health services in Uganda through a digital health portal. We had two broad objectives. One was to carry out a needs assessment in order to identify the gaps that were there that could be filled using a digital solution, and find out the opportunities to actually use a digital solution to provide mental health services. The second objective was to develop and pilot a digital mental health service support system that, if successful, could be scaled up in the future. And the background to this project is public health background, the fact that mental health is a global public health concern, affecting, as data show, about 1 in 4 people. And the time I've taken to talk to you, according to the latest data, somebody has committed suicide due to a mental health program. And the rest of the statistics that back up this study, you can see for yourself on the slides. But I would also like to add that when it comes to suicide from mental health issues, the latest report from the World Health Organization shows that actually Africa is the region most affected by suicide from mental health issues compared to the rest of the world. And so this project was a timely one in responding to this public health concern in this particular part of the world, and hopefully we can scale it up to provide the needed services. Mental health in Uganda is a widespread public health problem. About a quarter of the population reported to suffer from depression, for example. And when it comes to mental health care workers, the numbers are quite inadequate, as you can see there from the comparison with Sweden. Now, there's also lack of awareness of mental health as a public health issue, actually. And this is linked to a number of factors, which includes cultural beliefs, such as witchcraft, which affect access to the limited services that actually exist. And in Uganda, mental health care is facility-based or clinical focused, if I may call it so. There are primary health centers where outpatients could get support from mental health nurses. And then there are 3 regional referral hospitals where they are physician assistants and not psychiatrists for inpatient services. And all these feed into one national referral hospital, Butabika National Referral Hospital, that we collaborated with in this project. So in choosing our partner at Butabika, it's a strategic partnership that can actually lead to a national rollout of the program that we foresee in future as a result of this project. It's important to highlight that unlike other settings like Sweden, in Uganda, community-based services don't quite exist because of lack of resources, as I've mentioned. As I said, we had two objectives, and from the needs assessment, we had a few findings that informed the project, and some of them I highlighted in this slide. Mental health means different things to different people. There is inadequate awareness about mental health. As I said, people who have mental health illnesses could themselves or people around them attribute it to other things like witchcraft. Stigma and discrimination is also very strong, and that means that people and mental health facilities are stigmatized, and that affects access to services. We also found that the intervention that we proposed to develop was a welcome intervention, but suggestions to make it around the clock service 24/7 were made to us. And issues of confidentiality were also a concern from some of the stakeholders that we interviewed. And the challenge of having sufficient workload to man the services to meet the demand that would result from such a service were also highlighted. And of course, Uganda has a lot or several local languages, and it was recommended that all the languages should be available through the service. In other words, service users from different language orientations should be able to access the service without having the language barrier. And we also got a suggestion that the service should cover more or broader mental health topics. When it comes to the prototype that we developed, we set up a call center, if I may use simplified language. And the idea is that people call in to the center and get support on different areas of concern. It is a service based on pre-recorded messages. Unfortunately, we at this point only managed to support English and Luganda as the most commonly spoken local language in Uganda. And one key aspect of this intervention is that callers can get support by peer support workers who are trained. And basically, these are individuals that have had mental health illness and recovered, and therefore use their experience to support those who need help. And apart from that, the callers can also get access to mental health care workers, such as nurses and counselors, who are based at this facility. And what the hospital has done is that it has drawn up a rota so that when the callers make the call-ins, there is always availability of workers to respond to those calls at the particular time that the callers make their call-ins. It's a multi-channel service, and it's also toll-free, as well as accessible with basic phones. It doesn't rely on digital or smartphones, and also there's no need for internet. And all these were meant to reduce the cost of accessing service for the users. On this slide is a highlight of the pathway that callers can go through when they ring the service or when they make a call. They would first start by selecting a language, whether it's English or Luganda. And once they make the choice of appropriate language, they get prompts through other options, whether they want to get access to mental illness information or common mental illnesses that are covered within the system at the moment, or whether they want to talk to a person either the peer support workers or the mental health care workers. I would like to emphasize that given that we have many lines, there's very less likelihood that a caller would miss to talk to someone in case they need. But if they do, as illustrated, then they get returned back to step 2 after the language selection, where they can make a pick of either 9 to talk to somebody or get other information that they may need. Due to COVID-19 pandemic, this development of this entire pathway took quite a long time because it required a lot of iterations, and this was not quite easy when people could not physically meet to try and pilot all these messages. But in the end, we managed to launch the service in June 2022, and currently the hospital, the healthcare workers are using some of the data that has come through to modify and streamline their service provision so that the healthcare workers can be better prepared to respond to different needs of the callers. I would quickly want to highlight some of the potential impacts of this project. And I would start by highlighting that this project has responded to Digital Future's key areas, such as research excellence. It has created a multidisciplinary, multi-country collaboration involving people from different backgrounds, public health, mental health, and both natural and social sciences. And that fits very well with the goals of the Digital Futures research program. It has also created empowerment. It has involved both private and public sector, and it has actually led to progress from one of our collaborators, one of the researchers involved in the project, towards postgraduate, not postgraduate, but postdoctoral research to actually focus on looking at patient outcome of interventions such as the one that we worked on through this project. And also it has led to overall north-south collaboration and empowerment of different stakeholders that were involved in the project. For example, the peer support workers that have been trained are now well equipped to provide support to people with mental illness, not just through the call center, but also generally. The system has also led to, or the intervention has led to health system strengthening, and we believe that it would improve access to mental health care, and that gives positive outcome for positive health outcome for callers who may not need to spend a lot of money to go to the services and could actually access the limited healthcare workers through making a call. In my last slide, I just want to quickly present the researchers who were involved in the project. Dr. Caroline Wamala-Lashan, the director of SPIDER, Edna Somrer, head of digital health and organizational development at SPIDER, Dr. Juliet Naku, the Director General of Butabika Mental Health Hospital in Uganda, Marie Olinde, our PI, co-PI from RICE, and John Black Kabushie from Uganda Cancer Institute, who has since progressed to become a postdoc researcher through Digital Futures and would be looking at some of the issues that could not be covered during this period, like patient outcome from this intervention. We also have Vincent Michael Kiberu from Makerere School of Public Health, Makerere University. And at the beginning of this project, our co-PI from RISE was Peter Kiel, who moved on to a different role. And then we got the opportunity and the privilege to work with Marie on the project. And of course, myself, my name is John Owar, and I was the PI from SPIDER. Thank you so much for listening to this recording and for attending our session. And I hope you do enjoy the rest of the conference. Thank you and bye.